Well, welcome everybody, and this is a podcast we're putting together. That's myself, Danny Keenan, and Aoife Molloy, and it's part of the Clinical Audit Awareness Week. It's running from the 2nd to the 6th of June this year. There are a series of webinars at 12:30 on different topics. On Wednesday, the Wednesday of that week, will be indeed on ethnicity and deprivation and its influence on outcomes for patients. And that's essentially what we want to talk about. So welcome again. I'll just introduce Aoife. Aoife, do you want to just say a few words about yourself?
Thank you, Danny. Yes. Hi, everybody. My name's Aoife Molloy. So I'm currently the Senior Clinical Advisor for Healthcare Inequalities Improvement at NHS England. And I also work as a consultant in acute medicine and infectious diseases. So I'm really glad to be here today to talk about how we can really use data to inspire improvement and address inequalities.
That's great. Thanks, Aoife. So I'm Danny Keenan, Medical Director at HQIP. This is a seconded post from my day job, so to speak, which is in Manchester University Hospitals. So just to jump into the topic, so we've always known one way or another that ethnicity deprivation have really quite a big influence on patients' outcomes and other things to do with healthcare. And just jump in, Aoife, here if you like, as we're starting the talk. It came into very sharp focus during the pandemic. We were getting a lot of very good information, and I think many of us in healthcare found this very stark, that these two areas, ethnicity deprivation, were having a very important influence on outcomes during the pandemic. So armed with that and inspired by that, in a sense, we in HQIP, who have access to a raft of audits, with our clinical fellows who are each with us on a year's secondment from the NHS, we kind of did random reviews of several of the audits, looking to see, well, okay, in this particular condition or that particular condition, what was the effect that we would see to do with ethnicity or deprivation. And to be quite frank, it was depressing what we found, which was, whilst the audits were very good at looking at the obvious factors, sex, age, things like kidneys not working, heart not working, brain not working, when we got down to the kind of more refined areas, it was sporadic. So that led us to a more formal survey carried out about 2 years ago by Alice Bradley and Alice Conway, two wonderful fellows that we had working with us, who surveyed the audit providers, because in some respects the audit providers were a bit lost as to why weren't they picking it up. And they produced a paper which was really very, very interesting, which showed essentially we had various fundamental problems. There were 5 problems found, but the key ones were to do with coding. Now, we're not going to spend this webinar talking about coding, because that's a fundamental. But there were various themes came out to do with coding, and there were interesting bits as well. The obvious one being that coding was done badly. I'm not sure if colleagues know whether there's a setup for doing coding. I think it's that there are something like 16 codes for different ethnic groups, and then there are other codes for unavailable, not asked, answered, or whatever. The commonest codes coming in were the last 2. In other words, there wasn't being coded, which was very depressing. So. And when we went back and asked the audit providers who were providing this data to us, there were other things, important things, like the fixed amounts of money that they had didn't allow for, even if they had the information to analytic time. Analytic time is important. Mm-hmm. The other very important area in our world is small numbers. And we found frustrating things like, say, there's 16 codes, but then because of the small numbers, they were brought down to 3 codes, white, other, and something else, and that basically lost it all. So anyway, work has been going on in terms of coding, and to be frank, I don't want to spend the whole time spending on coding. So work that we've got that message, work is in hand, and indeed recent audits, and I'm going to quote some of those as we go through our discussion with Aoife, have come forward now in some respects of workarounds, so that we actually are starting to get information coming in on ethnicity and deprivation. I've said a few words now. Aoife, would you like to come in on what you've been doing in terms of this?
Thank you very much, Danny, and really good to hear about all this good work. And I think it's important to be candid about the challenges that we have, especially in terms of ethnicity recording and in ethnicity data in the NHS. And I really liked your reflection on the impact of the pandemic on how we approach inequalities in the NHS. And I agree with you that the pandemic was the very first time that inequalities were on the front page of the newspapers. But inequalities, as we know now with much more data, have been baked into our healthcare systems for decades. And I think the COVID pandemic really spurred on the 5 strategic priorities set out by NHS England, to restore the services inclusively, to have a real health inequalities focus on that, and to really look at digital exclusion with a health inequalities lens, and to accelerate preventative programs, because a lot of the deaths we saw during COVID were, as you said, with people with lots of multimorbidities, and these were concentrated in populations with lots of inequalities already. The leadership, strengthening leadership was one of the other areas that was part of the strategic priorities. But the one I really want to draw our attention to today is ensuring data sets are complete and timely. And this is really to say that we have so much data in the NHS and we have so much performance data, but it wasn't until COVID that we started looking at this data with an inequalities lens and an intersectional lens. And I found it quite shocking, actually, that flu vaccine programs, for example, had no data on ethnicity or deprivation or the sort of population breakdown of who was taking up the vaccine. And I think the pandemic really shone a very harsh light on the inequalities. But the response to the pandemic showed us what was possible using data to really drive improvements. So the COVID vaccination campaign is, I believe, one of the most successful public health interventions we've ever had in this country. It was audited by the National Audit Office, and they really found the same, that it was very cost effective, but very holistic and gave really good coverage. And the reason it did this was because we used data to really discover what people were at the margins. So we had about 80% coverage of the vaccination very early on. That looked really good, but the 20% were that same persistent 20% who are suffering with inequalities already, shorter lives, more burden of disease, more mental health challenges, more social challenges. And so really delving into the data of that 20% allowed a targeted intervention, and it was working with communities driven by the data to kind of create a better link with the NHS between these communities that drove up the vaccination rates in those communities. And that's really what brought us out of the pandemic. So the CORE20PLUS5 programme was really set up modelling its approach on the COVID vaccination campaign. So cohorting the populations, looking at that intersectional effect, and then using a very targeted approach, so not trying to take on every single condition in the NHS. So the CORE20 is the 20% most deprived, and that's defined at a national level. And I just want to mention that health is just one of the domains of the Index of Multiple Deprivation. So it does include things like housing, knife crime, employment, education. But we constantly remind ourselves in NHS England in the CORE20PLUS5 programme that we're focusing on what the NHS can do in terms of improving outcomes. So we can advocate for communities, but our main work is within the clinical outcomes and our clinical coverage, access, experience, and outcomes of care. So we also have, as well as the CORE20 plus population, we have the plus community, which is anyone who may or may not be within the 20% most deprived, but who may have problems accessing care or poorer outcomes of care. This includes people with inclusion health needs, people living with dementia, people with severe mental illness. And these groups are very much locally determined. And that is to really, again, use the data locally to try and drive a targeted approach to improving inequalities. So we have two programs in terms of CORE20PLUS5, two frameworks. One is for adults and one is for children and young people. Mm-hmm. And in the adults, we are focusing on the areas of care where there's the largest gap. And so this is driven by data from the Lancet Global Burden of Disease, but also by the national audit data. So we have a focus on hypertension. And that's because there's a huge gap in terms of cardiovascular disease outcomes between most and least deprived in England. We focus on COPD. And again, we're seeing very strong patterns of much higher rates of morbidity and mortality in communities with inequalities in COPD. We are also looking at severe mental illness, but looking at the physical health of people with severe mental illness. So we know there is about a 20-year gap in life expectancy between the general population and people living with severe mental illness. So it's really trying to build up those at regular checks and annual checkups and secondary prevention. The other areas that we're looking at are around early cancer diagnosis. And again, this is driven by data from the Lancet Global Burden of Disease study, but also data from our audits that shows that people living in deprived communities or people from minority ethnic communities end up arriving in A&E, getting diagnosed with a very late stage cancer where treatment options are running out. And so this is an area where we're really trying to push better towards early diagnosis in primary care and secondary care. And then finally, the maternity care is a huge priority nationally, and it's right in there in CORE20PLUS5 based on the Embrace data. And this is really a problem with racism in maternity care. And so I know the Health Foundation and NHS England and the Race and Health Observatory are doing a huge programme on really tackling the awful outcomes for Black and minority ethnic mums in the UK today. So that's the adults, and the children and young people are actually slightly different because the children's health is much more interwoven into society and education and family and housing. And so we couldn't use similar areas of clinical focus. So we're really looking at asthma, epilepsy and diabetes in children and young people, as well as mental health. And we know that that's a direct impact of the pandemic again, in terms of children suffering with more mental health concerns, but also waiting lists getting out of control due to COVID. And then the final area is one that kind of always gets me. It's the oral health. So we know that in England, the main reason children will have a general anaesthetic is to have teeth removed that are no longer alive, or they're gone rotten, and this has impacts on their psychological health, on their eating, on their speech, and this is a fully preventable problem. So that really is one of the areas of focus, and I guess just to really bring it back to how the data drives all of this. We have several programs, for example, the Ambassador Programme or our INHIP Programme, Innovation for Healthcare Inequalities Improvement Programme. And these are areas where we're really setting out aspirations to meet the NICE recommended care for all of the population, CORE20 plus. So this is what I mean about trying to do very targeted improvements in inequalities. The general population approach that we've been using for decades in the NHS doesn't tend to actually impact the communities that we really want to improve outcomes for. So I think the INHIP programme is a really good example. So that's the Innovation for Healthcare Inequalities Improvement. And so what we set out to do was provide a very targeted project to put a piece of nice guidance into place in a community with inequalities, with some funding. And this showed a wonderful success. What we found was the communities that were engaging in the care, their access increased, but also the access for their friends and family, their trust in the system increased, and their access to other secondary prevention opportunities like blood pressure control or lipid control improved as well with this one intervention. So I guess the improvements that we can get from focusing on the data go far more widely than the actual number we're looking at. And I think that's very important to remember when we're looking at the impact of our work, because we're often under a lot of pressure to justify our costs every year. And if we can't see a return on that investment, which is very difficult in public health, in the near future, it's very hard to sustain that funding. And then, you know, just to really mention that the INHIP program, actually the funding was ended, so we couldn't continue on a second and third wave with the funding that we had at the first time. But what was really impressive was the integrated care boards insisted on continuing using their own local funding, and they said, you know, we've got these teams set up, they're so committed, the communities are so bought in, that they just felt like they couldn't dissolve it regardless of whether there was funding coming from the centre or not. So I guess that's the way things have changed really since COVID, is that a lot of the funding is now being decided on a very local level. And I think for health inequalities, this is actually a real win, because it allows things to be targeted. However, we must always insist that this is guided by the data, and you know, the audits are a huge part of that.
Oh, thanks. Well, you can catch your breath now. Yeah. So there's several words you used there. One of the really important words is word trust. You know, the community must trust us. You know, they must, and that's vital. And then localism. I think this is really important. I think as we were setting out in all of this, we thought that a national initiative, you know, it doesn't seem to work. We've done that, it doesn't seem to work. And it's really heartening to hear about the ICBs. I know in Manchester there's been work going on locally, where in central Manchester there is a lot of deprivation, a lot of ethnic groups. And of course, these two go together, you know, the deprivation going with it. I just wanted to you mentioned children and young persons. So there's some figures that have always stuck with me, and you mentioned Embrace, which is a wonderful audit that we commission and run. But I was looking through this, and actually there's really stark stuff. I'm just going to go through this. I was looking at the last few days the information coming in stillbirths and neonatal deaths like that. These are fundamental. A society that's not taking care of babies, mothers, and neonates and the like. They've got a problem, and we do have a problem here. So just to go through this, in terms of the effect of ethnicity on stillbirths, and this varied over years, and between 2019 and 23. That 4 year, the trend is still there, but in the most recent figures between stillbirths in the black ethnic group and white, it's twice 5.84 in black group, 2.71 per 100,000 per thousand. That's a stark difference, a twice difference. Deprivation, actually, as to say, it's double deprivation. And so you can imagine when you stick the two together, deprivation, ethnicity, that's a really big difference. And it's also seen with neonatal death, ethnicity. It's not exactly as much as twice, but it's still not good. So there is something really important there. And we all know the figures to do with maternal death, which again is, you know, that's really not acceptable, and the big differences there. But this rolls on into other areas. You actually mentioned cardiovascular disease and the like, but we know from the CBD Prevent audit that the black group, black ethnic group, have a much higher incidence of mortality with stroke, and the Asian group have similarly a much higher mortality with the heart attack. You know, and these are areas that we should be grappling with and getting into. And then when you kind of come down the spectrum from death into other areas. Like, for instance, in terms of maternity, it's not just maternal mortality, but things like postpartum hemorrhage, eclampsia, and things. These are all higher in the ethnic groups. And indeed, I actually was reading through the what was it, the inflammatory arthritis audit. Now that's one that possibly you might think, it's not going to be hit on by ethnicity, but the percentage of those in the Asian and Black minority groups who have remission is less than the white group, so that there's things going on here. That's why we really need to concentrate on getting better figures, so as to try and the intertwining of ethnicity, deprivation, and all of the other factors, some of which we can deal with, others genetic and the like, which we can't. But that's why we need to keep going, looking harder and harder. And then there's other kind of very straightforward areas, like we've got a very good audit, very good in terms of ethnicity in the type 1 diabetic audit. That's very good because they have a colleague. Obviously, the numbers there are not huge like you would have with inflammatory arthritis. They actually track down every one of their patients to get proper ethnicity. So they have got very robust figures. And those robust figures show us that and these are particularly young people, getting implantable devices and the like to deal with monitoring sugar and delivering insulin. They're less. These are unacceptable. So getting these really important figures, because once you've got important figures and you can go out to an ICB, for instance, and it's fantastic to hear that they're getting really involved in it, because that's really, with all the machinations and changes going on, ICB, that the local delivery of healthcare will carry on, and having them involved, as you've described, is really excellent. And presenting them the information, so which is stark, as we've just gone, like I've just picked up a few examples, but there is very stark information in this, so that we can actually get a grip on this. When we were getting into this, when the CORE20+5 was starting off, I had thought, oh yes, well we'll get a national programme on that, and then as you've just said, it became obvious it's not going to be a national thing. It's the more locality. So that what was the name of that again? Because I think colleagues will want to hear about that local initiative.
Yes, INHIP. So it's the Innovation for Healthcare Inequalities Improvement Programme.
Yeah,
INHIP.
right.
And I think that is a very good vehicle for targeted improvement using data, and really to respond to what you said, Danny, about in particular maternity care, and then the cardiovascular disease as well. So in terms of maternity care, there's a fabulous report by Birthrights, and they've done a whole review of not just the access data, but the experience of care. And so they've interviewed lots and lots of women and fathers and families and healthcare workers. And what their conclusion was, and this always just sticks in my mind, it's that it's systemic racism, it's not broken bodies. And what they're really calling for is actually, really positive action on breaking down the stigma and the barriers to the care, the problems with access. And in response to that, I think, just to bring it back down again to the ICB level, there are some really fantastic programs that are going on around the country. So we have the Peri-Prem program, which is really looking at reducing neonatal deaths and stillborn. And what it is a kind of a whole package of care points that are proven to improve outcomes for neonates. But what they're doing is targeting at populations with health inequalities, and they're doing that with the communities. So again, it's key that there's trust, but also that there's community co-production, and so involving the families and the mums in a more sort of community-based care, rather than this kind of power imbalance between the healthcare service and the community. And there's another program called Black Maternity Matters. So they're really, really focused on addressing those, as you said, harrowing statistics. And I think the other thing I wanted to just mention about the cardiovascular disease is that that's been a huge focus in terms of INHIP, but also in terms of CORE20+5. But we did another look at some of the data around routine prescribing. So we looked at every single prescription that was written in the NHS in a year, in terms of routine prescribing, so not anything specialized like chemotherapy. And unfortunately, we weren't able to look at ethnicity because we're just literally looking at whatever is on the prescription. So we have the address, which gives us the deprivation. We've got the age, the gender, and we were able to see what drugs were prescribed. So we were able to sort of infer from the BNF chapter what they might have been used for. And what we found, again, was very shocking and startling. We found there were actually differences in prescribing patterns between the 20% most deprived and the general population. So people in the CORE20 population were getting second and third line antihypertensives instead of first line. And in terms of COPD, they were getting much more frequent prescriptions for reliever inhalers, and we presume instead of getting rehabilitation.
Yes.
And then in terms of the severe mental illness, people in the CORE20 community were being prescribed the more old-fashioned antipsychotics when that wasn't recommended by NICE. And so it wasn't an association study or anything, but what it really did was raise these very alarming questions about access and equity in the NHS, right down to the level of what's written on the prescription. And just to sort of address another area that I think is extremely important is looking at community languages and interpretation and translation in the NHS. And we know we're releasing a report on patient safety and inequalities next on May the 15th. And this is really exploring the experiences of families and patients with that intersection of inequalities and patient safety incidents. And what we've really tried to do is recommend best practice for each of the areas where there's been very concerning outcomes. And one of the things I really want to draw attention to is a program called Written Medicine, and it's an algorithm for a pharmacy printer, and it can print all the labels in 16 or 17 different languages. So the prescription label is in the language, the preferred language of the patient. And I think this just brings it back to what we were saying about the localism. These kind of things actually only work right at the heart of where the NHS is really taking care of patients. And that's where all the efforts and all our interventions need to go.
Sorry, absolutely so right. Yeah, so right. I think we've romped around this a bit, and we've had knocked it around. It's really great to hear where CORE20+5 is moving. Is moving in this local area, which is obviously an effective area. Though it's really been great to hear your insights into these various different regimes, etc. And hopefully, by using this podcast, we'll when we send this out, we'll have our emails and the like. Yeah. And colleagues will be able to get in touch with us. There is so much information, but in some respects, we got the message. We need to get on and do the doing.
Exactly. Yeah.
We're frustrated by wanting better information, but in some respects, we've got good enough information to show us actually, let's get on with this.
Yeah, definitely.
Have you any last things you'd like to say, Aoife, before we sign off?
I would agree with that, Danny. I think, just acting on the data that we have and, looking at those trends, those questions, and really delving further in. Yeah. And I agree with you. I think we always need to be trying to achieve better standards and better quality data, in particular in terms of ethnicity. And, and that is a national ambition, but all the way down to a local level. Yes. But I agree with you. I mean, we can't have, data paralysis. Like, we need to also try and make a difference. Yeah. Okay,
that's great. Well, it's been wonderful talking to Aoife. Always inspiring listening to all your thoughts. So again, thanks so much for joining us here for this Clinical Audit Awareness Week. And as I say at the beginning, you'll have our emails and I can get in touch with us. And this is really to spark a debate, that moving it all out into the community, our community as well, so that colleagues understand that we are frustrated, but what there is action, and what our fingers are crossed that we'll actually pull it off this time. Exactly. Thanks very much, Aoife.
Thank you, Danny. Take care.
Bye now.
Bye.